Good evening, everybody, and welcome to this South Asian Heritage Month event on health information for South Asian communities, lost in translation. My name is Binita Kane. I'm one of the co-founders of South Asian Heritage Month, and I will be your host and chair for this event. I'm joined by an amazing panel of both patient, experts, and healthcare professionals who are doing some incredible work in this field. Now, one of the reasons I wanted to pull an event together on this topic is that I'm a respiratory consultant myself, and I find it very difficult to signpost people from minority ethnic groups to good resources on pretty much any topic. You can find it sometimes if you search really hard, but it's not in one place, it's difficult to access. And also, I find that if there are patients who don't have English as their first language, they very much get second-rate service from the NHS. And it's almost a bit of a heart sink moment in clinic when I know somebody doesn't have English as their first language. We can't get translators in person anymore for some reason. The telephone line is an absolute disaster. So it's really, really difficult. And you know, we know that there are worse health outcomes in South Asian populations in multiple disease areas. And one of them, I mean, that's very multifaceted, multi-layered, but one of the things that may be contributing is how we communicate with our South Asian communities. We know that this is relevant to the Black population as well, but as it's a South Asian Heritage Month event, we are focusing solely on the South Asian population, so we won't be discussing any of the other minority ethnic groups today. I'm not going to introduce all of the panelists immediately because there's so many, but what we are going to do just now is go round and hear each of our panelists speak. They will introduce themselves and they will talk about some of the work that they are doing in this area. What we will then do is break into a sort of a question and answer discussion session. So please get involved, pop your comments and questions into the chat box, and we will try and pose as many of those to the panel as we can. So without further ado, I would like to start. I'm delighted by introducing Sonal Bhavsar, who is our patient expert and is a support group leader. And she's going to talk from her, a personal perspective, but also the work that she's doing about some of the challenges in South Asian communities. Over to you, Sonal. Don't forget to unmute yourself.
Hi, good evening, everyone. My name is Sonal Bhavsar. I've got a degree in Ayurvedic medicine. And I focus on people's health problem, how they can self-manage really. And I volunteer for Diabetes Self-Help Group, which was set up by me in 2012. The main idea came about this group was that my dad had diabetes, and when I was studying in university, I was trying to help him to manage his sugar levels. But I didn't know how to help him. I was just kind of constantly focusing on his diet only, and he was the kind of person, he used to like his food, Asian food, deep fried pakoras and sweet and everything. So he used to have lots of them. And my granddad was also diabetic. But he was completely opposite than him. He was focusing on his lifestyle. He was a yoga teacher, and he was focusing on his food, what he was eating and everything. So they were completely different personality, but they both had a diabetes complication. So I always had that in my mind that I want to help people with this condition. I'm having this background. I didn't realize that I will get the diabetes when I was expecting my third child in 2004. So I had gestational, and then my feelings increased that I want to help more people. And I thought, in this country, what can we do and how can we help people? So I thought that if we can educate people about how they can self-manage their condition, that would be good. So that's how I came about setting up the group. And we used to meet once a week, and then we started meeting twice a week. And what we do is share each other's experience and feelings. Usually people are used to going to doctor and taking medication, but they don't do anything about their personal lifestyle changing or diet changing or keeping themselves fit or focusing on their sugar level. And sometimes they don't even know what to do. So when we come to the group, we share different topics in terms of medicine, diabetes, type of food, focusing on specific food, physical activity, isolation or social interaction. We talk about different topics. A lot of the time we have professional coming from different background and they give a talk. So we used to have GPs, nurse, or eye retina people, and many others. So we continue doing workshops. Then slowly we gradually expanded in different kind of subjects, art, physical activity or walking, and lots of yoga and breathing techniques. So how we came about expanding this, people started, the members, actually local members, started to feel good about it. They got lots of knowledge about their condition. Last couple of years, we call is diabetes self-help group, but we allow non-diabetic as well, because it's all about all health problems. We also focus on telling them about contraindication or long-term complications, so they can be aware of it. So more we do is about raising an awareness. And recently we were given small pocket park in Leicester, corner of Moira Street and Melton Road, where there is a small little park which we do, where we do physical activity, gardening, and it's nice to have that kind of places. And we focus on keeping our mental and physical health and well-being into kind of balance. That's how people meet. And mainly we meeting recently, well, since pandemic, we meeting on Zoom. And those who are not able to come on Zoom, they're coming to this park, and slowly, gradually, we helping people, our members especially, to get back into the social interaction. So my main passion is about helping people in any kind of health condition by self-manage and making them aware of their own condition and help themselves. Thank you.
Brilliant. Thank you so much, Janelle. And I think there was so much in that I really want to kind of talk to you about. But what I'm going to do is come to the other panelists first, and we'll definitely come back to you on some of those points that you made. But thank you so much for sharing that with us. I'm going to go next to Naseema. Naseema is a community engagement officer for the Centre for Ethnic Health Research, and that organisation is doing a lot of great work in this area. So over to you, Naseema.
Thank you, Binita, and good evening all. I'd like to say I'm working as a community engagement officer for the Centre for Ethnic Health Research, as you've mentioned. And I also work for the Bangladeshi Youth and Cultural Shamati, which is based in Leicester. And I'm going to just talk a little bit about my experience and the work that I do with the members of the community to support them. And I mainly do that through information and education. So I speak a couple of languages. I actually speak Punjabi, Hindi, Urdu, Bengali, and a little bit of French, but I deliver a lot of services, which entails basic literacy, ICT, parenting skills, physical activity sessions for women, which involves yoga, dancing, healthy eating workshop for families, health topic workshops to communities, and information, advice and guidance. And I researchers, study teams, managers, PhD students, and I support a lot of studies. So primarily I've been involved in working with translation work, because it is required, especially with the South Asian communities. They don't really absorb a lot of information. So I've been involved in the self-risk assessment screening tool, which is online tool, as well as we've got hard copies, and they were translated in different languages, South Asian languages. So Bengali again, Urdu, Gujarati, and Punjabi. It's a tool to screen yourself whether you are at risk of type 2 diabetes. So you can assess that by going through the 7 questions, whether you're at low risk, medium risk, high risk, or very high risk. And I've also worked for the Safe Ramadan, which is delivered through a community setting. And these are, again, different languages. So if people have type 2 diabetes, they are not well managing their condition, it's giving them information, awareness, and advice to better manage that during the month of Ramadan. And recently what we've done, we've also culturally adapted the Desmond program, which is adapted in different resources. For example, food resources to meet the relevance of the communities, so that they actually absorb the information and feel that it's relevant to them, and they can better engage within the education program. And that is for the people that are newly diagnosed and existing diagnosed patients with type 2 diabetes. And we're due to deliver this session actually this month in Bengali and Urdu, Hindi, and Punjabi. But I also have a public health background, so my work ranges in delivering workshops, anything to raise awareness within the communities, and I do that in collaboration with the community centre that I work for. So it kind of goes really well, because they prefer to be engaged within a community setting rather than perhaps a hospital setting, because that is more comfortable to them and trusted. Yeah. That is all I'd like to say. Thank you.
Yeah, thank you so much, Naseema. Again, there's so much in there that we could talk to you about, and I definitely want to come back to some of the points that you raised there. But thank you for sharing your work. I'm going to move on now to Dr. Seaman Prinha, who is a qualitative researcher at the University of Oxford and a psychotherapist. Also has, I just want to say thank you, Seaman, who's really helped pull this whole event together and put this wonderful panel together, and has worked hard for that. So Seaman, I know you're doing some really interesting work in this area, so do you want to tell us about it?
Yeah, thanks, Binita, and thanks to all our panelists, especially Naseema and Sonal, who've just told us a little bit about their work, which is brilliant. So I've been conducting research for over 20 years into patients' experiences of a range of conditions. And this includes patients' views on the health information that they've received and their information needs. But I'm going to talk really briefly about South Asian patients' views on the need for culturally appropriate health information, and about co-producing educational resources for Asian communities. So we know that there's a lack of research into the lived experience and information needs of South Asian patients with different long-term conditions. There's also a gap in research into the best ways, or the optimal ways, the most impactful ways of developing health information for South Asian populations. So working with Sonal and Naseema, we've worked together for a number of years, but more recently we conducted workshops with Indian, Pakistani and Bangladeshi communities. And we asked participants about their views on COVID-19 health messaging. We also showed them a 6-minute film, a short film, a 6-minute video to prompt discussion on developing information for Asian communities. We used type 2 diabetes as an example because we know from our previous research that South Asian patients with diabetes do want more and better information. Our full report, which was recently published, is available online. But very briefly, summing up some of the findings in our report, our participants, all of the participants that we spoke to, said that culturally relevant information is vital for several reasons, not just because of language barriers, but also because this information can help fill in gaps in the knowledge of patients with poor access to healthcare, as well as those who don't speak English or read English. This information can also promote self-management and self-care and raise awareness. It can also improve communication between patients and health professionals. And it can also help break taboos or dispel myths about health conditions, especially sensitive issues, including depression. So there was a clear need identified by our patient and public contributors. They also said that videos in different community languages with subtitles were the preferred format for educational resources. And they talked to us about the content and the length of educational videos. And they said that they wanted clear, simple, consistent information from health professionals that's evidence-based. And they also wanted to hear about the experiences of other South Asian patients. So people from similar backgrounds, people who they said looked like them and were from their communities. Their views highlight the importance of co-producing educational resources with patients and health professionals and other stakeholders working together so that we can ensure that any resources that we do develop are acceptable and relevant to patients and their families and disseminated widely. And my final point on co-production is that co-production includes working together and all of us learning more about the challenges that we face, patients, health professionals and researchers, when it comes to giving or receiving or developing health information. So we've heard some patient and community perspectives, and it would be great to hear some health professional perspectives too, in terms of some of the challenges you face and maybe some of the things that work well too. So thanks, Binita. Back to you.
Sorry, something's happened to my, there we go. It wasn't, the buttons weren't working for a second there. Seaman, thank you so much. That was actually, I have actually seen that report and I have read it, but it was a while ago. But there's some really fascinating insights into there. I suppose no big surprises, but the surprising thing is how little we act on that information and the fact that that is, you know, a new report, and that here we are in the 21st century. So yeah, I think there's so much for a rich discussion there. Moving on to then our very first sort of healthcare professional working in the NHS, we have Professor Kiran Patel, who is a consultant cardiologist, but also heavily involved in the work of the South Asian Health Foundation. And, you know, I guess for you, Prof, it's about that big picture. You know, at the moment, it seems that there's lots of really amazing people like Sonal and Naseema doing wonderful work, but they're just individuals championing a cause, and actually what we need is this to be much more widespread. So I'll just pop you on the big screen. Just give me 1 second. There you go. But yeah, thank you. Great to hear from you.
Yeah, thanks, Binita. And I think it's really inspirational to see everybody here talking about a really important topic. I'm going to take you back to the 20th century when I started. I'm going to show my age and say about 30 years ago. I remember seeing my first patient who was South Asian and had a premature heart attack. And as part of the rehab program, his family asked me for some information to say, how do we change his diet? How do we look after Dad? And I went to our cardiac rehab nurse and I said, well, do you have any literature for South Asians? And she said, well, no, we haven't, but leave it with me for a couple of days and I'll get back to you. And she got back to me with a leaflet that was literally a translation of how to make a steak and kidney pie, written in Punjabi. And I looked at it and thought, this is not appropriate. We need something better. And my journey as a cardiologist, through areas of deprivation in Birmingham and Sandwell, where I've worked, and now in Coventry, where I work, I've really come across South Asian populations at large who needed a lot more doing. So I, as a registrar, I formed the South Asian Health Foundation, and very quickly got the philanthropy of a lot of healthcare professionals. And of course, the NHS has got 30 to 40% of its workforce from a South Asian background, and everybody wanted to help their communities. So we harnessed that and launched the South Asian Health Foundation about 25 years ago. And very briefly, what that does is three main objectives. One is advocacy. So we help to influence national policy and NICE to make sure that health equity is really at the forefront of everything that we do. And, one of the really great documents we produced early on was the NSF for coronary heart disease in South Asians, which then catalyzed organizations like the BHF and a lot of mainstream NHS bodies to say we take this seriously and we tailor healthcare for the South Asian population. The second aim is that we catalyze high quality research and education. And every year we get together and have a conference for over 200 individuals in the UK. But of course, this year during COVID, it went virtual and we had over 3,000 people online. So it became a global conference where we disseminated really good high quality research and evidence to say how we manage diabetes and coronary disease in particular in Asians. And then the third area really is community engagement. So as Seaman has told us earlier, we need to produce material and inform our populations and communities in the way that they want to hear. So we produced a lot of literature which is simply translational based. We produced DVDs in a Bollywood style, which were really well received. That was fantastic. And then, of course, we've got into communities and held engagement events. And the engagement events, I think, are really interesting because they focus around making sure that services are available for our populations, but actually they need to be aware that they exist in order to access them. They need to be accessible in areas, in communities, and there's a lot of our healthcare that can be delivered at a grassroots level. The services need to be acceptable, and the example I'll give you is cardiac rehabilitation for women from a South Asian background, and there are areas that do this very well. And then, of course, we need to make sure services are acquired, so really good audit and evaluation of NHS services is vitally important in order to make sure that health equity is at the core of everything that we do. But I hope that gives you a brief flavour of the kind of stuff I've been involved in. Thank you, Binita.
Thank you so much. And I'm a little bit ashamed to say that I only found out about the South Asian Health Foundation, in the last few years. And I think it's a shame that charity that's doing such good work, well, A, that it has to be a charity doing this work rather than it being a mainstream driven by the health service, but B, that a charity doing such great work, I would say that a lot of my colleagues, for example, may not know about it, and perhaps one of the things we can discuss afterwards is how we can get that message out more widely. But perhaps we'll come back to that because I'm just conscious we've still got a couple of more people to speak. So next, it gives me really great pleasure to introduce Leonos. So just give me 1 sec as I switch my screen around again. Leonos Jones is a fellow respiratory consultant in Mid Yorkshire, and we got chatting about this a couple of years ago, and I'll let Leonos tell the story. In fact, you go, you tell the story, Leonos, and then I'll come in at the end.
Well, my story actually starts about 10 years ago when I became a consultant at Mid Yorkshire. And for those of you who don't know the area, it's an area where there's lots of people from the South Asian community live in my patch in and around Dewsbury. And I'd worked there for about 6.5 years when I was off on mat leave with my youngest. And I was tasked with setting up, when I got back, a difficult asthma service there. And having worked in the area for about 6.5 years, I knew that my demographic was such that I would need things in different languages, and it was just really obvious. So I started ringing around pharmaceutical companies. I remember doing so with my little boy bouncing on my hip and thinking, oh, this will be no problem. I'll just get a few leaflets together and everything will be fine. And actually that information didn't exist. And I was really, really dismayed. I knew that to make it a successful service, it had to be an equitable service, and to not provide that information in different languages was just wrong. And for those of the eagle-eyed amongst you, probably realise that I don't speak English at home as well. I'm a Welsh lady, so I don't speak English as a first language. So to be sitting in a clinic saying I can't give you information in your own language, I've only got it in English, was just too painful and not acceptable to me. So I started lobbying pharma companies a few years ago with varying success. I have managed to get a few things now translated, but it's a bit more than getting things translated, as other people have said before me. It's about putting it in the right social and cultural context. Just translating a pamphlet just was never going to be quite enough, and so I've applied and been successful in obtaining a rather large grant this year. It's called the Pathway Transformation Fund, and through that I'm hoping to build on some of the amazing work that was done in Leicester a few years ago with the South Asian Respiratory Initiative, when they did lots of amazing qualitative work around sort of focus groups in the communities, looking at what's acceptable, what wasn't, the barriers to accessing care, the stigma around a diagnosis of asthma, cultural misconceptions, all these wonderful things. And what I'm hoping to do is develop videos that would be freely available, graphic medicine, so that's languageless resources to explain how to use your inhalers, what asthma is, all that sort of thing. The other thing that I think is key is, and a really important part of the project for me, is to try and get some community champions. I think it would be lovely to get people to learn from within their own communities. And so we're looking at that as part of the next 12 months, part of the project as well. I do think that in my own journey, I've learned so much about the cultural side of things and how things differ within different communities, and I just don't think that there's an awful lot of awareness about that. I'm very motivated to learn. I want to provide the best service and the best care I possibly can, and part of that is learning about people's culture, and it's a great joy to me. And what I'd love to do is to really go and educate other healthcare professionals who might not be aware of some of the issues. It's quite common for me to come across people who aren't aware of these issues. And I gave a talk about this at the British Thoracic Society, which is where Binita and I linked in right at the beginning, because people were fascinated. People were coming up to me after the talk, so I had no idea that all these issues were present. I also think it's really important that we lobby for more information to be gathered in terms of people's ethnic, more data about ethnicity, more data about language. It just doesn't exist. It's not out there. Something like the Severe Asthma Registry, it probably records things like that. And so to be able to go forward, we need actionable information and we need more data. I think after all this, I think we also need to be trying our best to work together, sharing our experiences. I've been fascinated by what I've heard so far this evening. I think we could do with also having a repository, so that we have somewhere that patients can go to and healthcare professionals to access this information, because again, that's really important as well. Thank you very much for your time.
Thanks, Leonos. And I think one of the things that me as somebody is from South Asian background, you who isn't, we've had the same degree of training in how to deal with, cultural issues. And, and even as somebody who is South Asian, I know about my community, but I don't know about different, my neighbours' community. And we just don't get any training. And I know that Enam, who'll be speaking soon, is trying to change that with the University of Manchester and the stuff that we're teaching our medical students. But we don't stand a chance, do we? We get churned out of medical school without a clue, and then it goes downhill from there pretty much. So thank you for sharing that, Leonos. And I thought actually one of the main reasons to invite you as well, so you could network with all these wonderful people who can help you with your project.
Thank you.
I'd like to introduce Rais Lunat now, who I'm a big fan of. Rais is a GP registrar, Deputy Director of the NHS Staff Safety and Staff Vaccination Programme for Health Education England. So Rais and I have worked together on some of the vaccination issues around low uptake amongst NHS staff from different minority ethnic groups, and has been a big help to me in doing some of the work that I've done. But I really wanted to invite Ray to talk about some of the amazing work that that group has done to improve outcomes in vaccination rates, and particularly about how important representation is. So I'll just put you on the screen, Ray. Just give me 1 sec. There we go. Over to you.
Thank you, Binita, and thank you, colleagues, for putting on such an amazing event, especially around such an important topic. And as Binita just mentioned, I'll be spending a few minutes just giving some of my own personal reflections around the work being done at NHS England Improvement on the COVID-19 vaccine programme. So when we embarked on that journey, which honestly feels like a few lifetimes ago now, our main aim was to avoid a double tragedy. Everyone was aware of the differential impact of COVID-19 on BAME populations, BAME individuals, BAME communities. And what we were really adamant about was ensuring that BAME populations weren't left behind in vaccination and weren't essentially those individuals who would keep on getting COVID again and be affected by a double tragedy. So that pretty much led us to carrying out a series of focus groups, using behavioural insight analysis and experts. And a few of the really important nuggets which came out included: who are the actual decision makers in these households? Is it a typically matriarchal society? We have to understand that children actually hold a really important role. So often whether someone would take a vaccine would be down to the 25 or 30-year-old who often wouldn't live at home but would have a large sway of influence over their parents. What information do people from our backgrounds actually consume? And more importantly, where does this information come from? So we found a lot of the information was actually WhatsApp based and not from the UK. So people were being influenced by media consumed perhaps in India, Pakistan, videos, not NHS official resources. And the other main thing that came across is that people wanted to be treated by individuals that look, sound, and communicate like them. They wanted that real onus of trust with their healthcare professionals. And the final main thing which we established is where, the site of delivery. People wanted to be treated in familiar settings, whether that was mosques, community centres, mandirs, temples. They wanted somewhere which they actually acclimatized to as home. So putting all of this together, this led to a series of concerted efforts, some of which were the more basic things, for example, leaflets in different languages distributed across the country. We managed to sign up over 120 places of worship to be used as vaccination centres. And then general practice and general practice colleagues in those communities actually started delivering health checks. I think one of my fondest memories of the vaccine programme rollout was actually visiting a mandir in North London where elderly people were actually going for their vaccine, then having an HbA1c blood test, and then having blood pressure counselling all done in the same centre by people that looked, sounded and communicated like them in somewhere which they recognised at home. We furthered our efforts with things like Ramadan guidance, Vaisakhi celebrations, etc. And Binita actually hit the nail on the head on the importance of representation. And one community where we actually focused on, we noticed that uptake was particularly low in, for example, the Bengali community. And it was only until we had some support from individuals like Nadia Sain from Bake Off, where following a campaign led by her and with the NHS, vaccine rates skyrocketed. So over an 8-week period, the Bengali community increased their vaccine uptake rate quicker than any other community due to the importance of representation by individuals like Nadia in mainstream media. There are and there will be challenges, whether that be scale, moving from national to local implementation, but a huge challenge is actually diversity. South Asian culture is so all-encompassing and diverse. Whatever sort of implementation you produce needs to be all-encompassing of all cultures, religions, faiths, etc. And that continues to be a challenge going forward. I guess the main challenge for NHS England and colleagues and individuals on this call is how we harness those positive lessons and all those gains which you've had over the last 18 months in what's been a terrible time, and how we use those going forward to improve health equity and move that forward as part of system recovery. But I'm left with a lot of confidence by the enthusiasm by individuals on this call that hopefully we'll be making huge strides in that area going forward. Thank you, Binita.
Thank you, Rais. And I think I've learned a huge amount from being involved in a very small amount of, part of that programme. And I think having Perina Issar as our Chief People Officer as a woman of colour made a huge difference, in driving the change. I think firstly that. secondly is I just didn't realise how different the inequalities were, even within just the South Asian population. You know, with you know, there's just a hierarchy, isn't there? And we know that the Bangladeshi population often has the worst outcomes. And how stark that was. I think, you know, I just hadn't realised quite a lot of this stuff. So, you know, when people, I don't know, think that they can attend a course or something and then do appropriately cultural information, it's really not that straightforward. And it's, you know, and it just shows that when the nation puts effort into tackling this problem, you can actually make a difference. But it was only because it was important for the whole nation, probably, that effort was kind of put in, if you know what I mean, rather than it just being a focused effort to help minority ethnic groups. And I think that's a little bit, you know, a little bit sad, but also positive, because there's been so much learning from it. Okay, so last but not least, delighted to introduce Enam, who has got lots and lots of strings to his bow, but he's a GP in Manchester and has done some really fantastic work with a group called Askdoc. So I've asked him to come along and speak about that. Over to you, Enam. Let me put you on the screen, just one sec.
Thanks, Binita, and thanks for the invitation. And I'd like to echo what everyone said about this South Asian Heritage Month. Excellent work, really important topics covered. I love the food section particularly. The only problem was it was happening at times when I was really hungry. I stared at my meal and I looked at the meal on TV, so that was a big contrast. So I've been asked to talk about Askdoc, which is a Greater Manchester organisation that was started in 2011. And all I wanted to do is just say what our principles have been. We've tried to keep it very simple, and then we've had an exciting journey and ended up, which is something like my own life as well, in places I never expected to be. And I continue to go on this crazy journey. But our main aim has been to engage the communities, to actually go to the places, because I think in terms of the literature, there is a lot of evidence of one of the barriers to access is going to the health centre or going to places where it seems more difficult to engage with healthcare professionals. And I love the work of the South Asian Health Foundation and all of the work that's been done in NHS England and by yourselves as groups and individuals. And I think that is the way we've always approached it. We've been going to the community centres and the places of worship where they feel comfortable, our populations feel comfortable to ask the questions. I think the education is important and to dispel the myths. So having culturally appropriate material is really important. And sometimes it can backfire. So there's one where I tried to be funny and I put up a slide with, is it halwa puri? It's very tasty anyway, but I shouldn't be promoting that as a healthcare professional. And I was joking and saying, is this hands up if you had this today? And I expect no one to put their hands up because I thought they'd be aware, and this guy put his hand up. And he killed the joke because it wasn't funny anymore, because he actually had it and he wasn't aware of how damaging it could be to eat it. Now, I'm not saying don't eat your halwa puri, but have it very sparingly. It is tasty, but I didn't say that. The other thing is empowerment. So we've been engaging our communities and gone to them, we've educated them in simple language and in their own language as well, and in terminology that they can understand and what they can relate to. And then it's that empowerment to give them their control of their own health. And I think that is the important thing, is the power of the patient in changing their lifestyle, understanding their disease, feeling in control. And I think that is a really, really important thing. And in undergraduate and postgraduate education, that's what we are now emphasizing, the power of our patients. And we've had a very interesting journey with the pandemic. We realized that there was a gap where we couldn't offer resources to our patients. I work in inner city Manchester, which is very diverse. Lots of nice food there. Sorry, it's all about food today. And what we found was, from a shout out, loads of volunteers came along. people who wanted to make a difference. And we managed to get videos done very, very quickly. I've learned how to edit movies based on that, which I did not have any skills at, and I probably still don't have any skills at, but I had to learn how to do it. And I would say, as well as the patient population to engage, educate, and empower, it's important to find like-minded people who understand and get why these issues are facing our community, got the lived experience, understand the community, and are willing to give back and do it in a way that is the language they use is in the language of those communities, in a simple and clear, emphasized.
Fantastic, thank you, Enam. And I know certainly I have signposted lots of people to your videos with Askdoc, and NHS England adopted them as well as part of the kind of pack around vaccination. So it's really great work, and I think there's some, like, those principles are, you know, about engagement and empowerment are so important. So that's all of our panelists. We are missing one, Dr. Harpreet Sood, who sadly had to give a last-minute apologies for the event, but he was going to talk a little bit about digital literacy. So we've talked about videos and information in different languages, and he was going to give us his thoughts on that. So just we're not covering that obviously now as he's not here, but that's a very, very important thing that can make inequalities worse. We've had a comment from Nahid Razak, which I think is important, that not everyone can read or write their own language. So actually translating stuff into community languages is not going to work for everybody. And I guess it's not just language, but dialect too. Yeah, absolutely. So I can understand Bengali, and then I went to Bangladesh and I thought I could understand my grandmother's Bengali because she was from what is now Bangladesh. I couldn't understand a word anyone was saying, as the dialect was so different, and that is true. So I'll have some Bangladeshi people come into my clinic, and I still can't converse with them or understand what they're saying because of the dialect. So it's a massive challenge. A few more comments from Nahid, which I think worth flashing up. It's not about bridging the gap. It is about bridging the gap between generations. Absolutely, I think that point's been made by a few of the panelists. So this is just about the digital issue. So Nahid works at Walsall NHS Trust, facilitates a BME breast cancer group that was operating during the pandemic, and then the challenge of doing it online was huge. We actually, I'm talking about just my ordinary local COPD peer support group. We just had to give up actually when it went online. It just wasn't working. And no information on IT or help for them. So that's all very, very relevant. So thank you for those comments. So what I'm going to do now is just have a little bit of a discussion. Gosh, we're actually a little bit short of time. We've probably got 15 minutes left. So I think we'll just do some quick questions. But I wanted to just go back to Sonal and Naseema about some of the work they've done, and maybe even picking up on that point about it's not just about translating stuff into languages. So when people think they're doing diversity, that's sometimes, oh, tick, I've got 5 different languages, that I've done it. How important was it for you, Sonal, that your group was led by patients for patients? And how important do you think that it was that you had it was integrated with healthcare professionals? So it's not just patients going off on their own doing it by themselves, but actually it's supported by the NHS as well. Any reflections on that?
Yeah, thank you for this question, Binita. It's very important, I guess, because they can be guided in proper way and right way. If there is something about the medicine they want to know, if there is something about how their body works and how their sugar level is going up and down and why. So if there are professionals around in our group, then they are guided in a right way and right path. So that's very important for our members, and especially it's coming out from South Asian mainly in local community. All our members got similar situation in terms of like either they have diabetes type 1, 2 or gestational, and they can then share their personal experience and journey, how they coming over. It could be stress, it could be personal circumstances, or it could be how the medicine is helping them. So when they share each other's experience, it helps them to understand that they're not only there. In most of the time in a South Asian community, we have got the stigma. When you have diabetes, they don't want to kind of share with amongst people. And if you are in party or wedding somewhere, they want to eat sweet or carbohydrate and spicy and oily food, but they feel that they cannot, and also they feel left out and feel alone, and it doesn't help them to overcome their barriers. So it's very important when we meet up, we share each other's feelings, and then they can learn from it and they don't feel that they are alone.
And I think that stigma is across a number of different conditions as well, including cancer and all sorts of conditions. And I think the more we can be open about it and talk about it, and the more people can support each other, that's only a good thing. So it's just brilliant work that you're doing. Naseema, any reflections from you just about the importance of having that representation of patients, educating patients?
Yeah. In terms of the translation work that we've done, we did not just pitch it at a high level of translation. So we pitched at 12 years age range. So when we did the translation of the self-assessment risk score, obviously not everybody understands, read and writes any language that they actually speak. So we have done visuals, and which is video resources, and especially for COVID, we've done multiple resources through the centre to get our information across. So they were all done in Silati, Shuddha Bhasha, which is this book language, obviously the posh way of speaking, but we've done multiple infographic videos as well to get those messages across. So it's really important to be inclusive. So we have done that in the recent months that's gone past. And also in terms of dialect issues, we have picked that up. And Silati Bhasha, you've got Shuddha Bhasha, and I've learned to speak those languages myself, and the dialect as well. I've picked it up through working at the community setting, and that's over the 5 years of my work. So I feel quite privileged to have done that, because I didn't understand a word last 5 years ago, and now I can pick that up because some of my colleagues are actually from Dhaka, which they speak the posh book way, I call it the Dhaka Shuddha Bhasha dialect, but I speak Silati.
Amazing. That's really impressive, Naseema. You've completely put me to shame now.
I love languages. I love to grasp. I wish I could learn French more than I can speak right now, but that was for GCSE. Just about passed it with a B grade, I think. Yeah. Brilliant.
And Seaman, any reflections from you just on that conversation? About having it's accessible. There's somebody who looks like me, somebody who's a patient, but I've got access to experts as well through nurses or doctors joining in these groups.
Yeah, it's really important to have all the information. So if you have a video resource, information from health professionals that provides context, and then information from patients about their personal experiences. So a typical educational resource might be, say, 20 or 30 minutes, but our participants said they wanted the information from health professionals as well as patients, so not just one or the other. And we talked about the length of resources, for example, and they said that if there was, for example, a 30-minute video, that should also be available in bite-sized chunks. So if somebody wanted to hear more about diet management for type 2 diabetes, you could click on just that. But it's also available for people who want to learn about various aspects of diabetes. So it was really important that the videos were in different community languages and had information from health professionals and patients, and that they were disseminated widely. So in community settings, healthcare settings, places of worship, but also on social media and WhatsApp and workplaces. So dissemination was also important, having that information, but knowing where to find it. So once the videos are produced, disseminate them widely.
Yeah, brilliant. And it is a challenge, isn't it? Because even in Manchester, I think we've got 300 languages or something. I mean, it is a challenge. I mean, we've got to start somewhere. We can't do it all. But I guess that I hadn't realised actually what the Aunties WhatsApp network is actually like. My God, it's, you know, news spreads via that network, and I think it's catering to that, you know, it's the YouTube, it's Generation Y and Z or whatever they're called now, and the millennials. It's catering to them, but actually some of that culture's spreading through to the older generations as well, but via WhatsApp very specifically. So yeah, I think multi-pronged is the answer, isn't it? It's not going to be one shoe fits all. You've got to have long videos, short videos, written, online, and then some face-to-face stuff as well. Okay, that's really helpful. So just moving on from the kind of you know, individual patient groups more to a organizational type of approach. Leonos, what do you wish you'd been taught before you were spat out as a junior doctor?
Where do I start?
Yeah, really briefly. We're running out of time, but yeah, I know there's a lot here.
I think, to be honest, I think it would be lovely if all medical students were just made aware that there are cultural things that actually pose barriers to accepting healthcare, because I didn't know that. I found that out through learning through patients and from colleagues, you know, who are from the South Asian community, and that's just one community. So I think just making people aware that you need to be interested in this if you're going to deliver high quality care that's equitable, because it's just not there at the minute. We don't need to know everything about every single community. We just need to make people aware that they need to educate. You know, who knows where you're going to end up when you're turned out as an F1? You know, you might end up completely different country or a completely different part of the country that has their own specific demographic with different needs. So I think just getting that message to medical students right at the start, and other healthcare professionals, that you need to seek this information, you need to learn more if you're going to be a really sort of equitable, you know, doctor at the end of the day. That's what's important.
Absolutely. And I think you know, not just making people aware, but also reversing some of the awful stereotyping and you know, this awful sort of thing. When I was in SHO, I'm talking a long time ago now, in the 90s, but sorry, in the early 2000s, I'm not that old. You know, there was an Asian woman who'd come in with, you know, pain, and then people would call it Mrs. Begum syndrome, or, you know, and it was a bit of a joke. And those stereotypes, I think, still do exist and have been perpetuated because people learn from their seniors and perpetuate those. So I mean, we've not only got to promote cultural awareness, but we've got to undo all of that kind of, you know, stuff that's driven by systemic racism as well. So it's a big job.
Absolutely. And also, like, not all doctors aren't willing to listen. I love learning about this stuff. Not from the community myself, but I absolutely love, you know, I've been a consultant, I said, for a whole decade, but I feel now that I learned so much from my patients. I've done all my exams, I've passed my membership, you know, all that sort of stuff. I've got my CCT, and actually now I've got the point, I'm just learning from so many different people in so many different ways, and there are lots of doctors like me and healthcare professionals like me who just love learning and throughout our careers, and this is a really important thing to learn about. So empowering people to tell me, you know, I ask people, you know, do you do steam inhalation? Do you do, you know, sort of, do you avoid certain foods like rice and milk if you've got your asthma? You know, I ask those things, and actually research does suggest that people expect us to ask. Yeah. So empowering people to tell us and to maybe ask these questions about things would be important as well.
Thank you, Leonos. And, you know, good luck with the project. Enam, I'm just going to bring you in there as well, because I know you are trying to change things at, you know, this medical student level. Just very briefly, can you kind of tell us what sort of work you're doing there to try and churn out better doctors, more aware doctors?
So I've recently started a role with the Medical Schools Council, the EDI Alliance. We want to make some changes, so it's great to hear from us and others about the enthusiasm. We're looking for like-minded people to change it, because I think that is key. There is a culture there which has been perpetuated by my generation and the ones before, where the stereotyping in problem-based learning cases, the stereotyping of our patients and categorizing them, we need to just start afresh again, because we're in privileged positions. There are issues of racism for staff, for students, for patients, and we need to change that culture. So hopefully we will do that. I mean, today I had a nice conversation with RES, the Workforce Racial Equality Strategy, and we just said we can't be doing this anymore, because there is direct links to health inequalities because of the barriers and the racism and things. I won't go too controversial, Binita. People can see my tweets if they want to see my full
It's
story.
not controversial, it's the truth, isn't it? So it's just it's factual stuff. So that's another whole conversation. We could actually have another entire event about that. But it was really great recently. I looked after one of your medical students who was on a health population placement, and it was just wonderful just being able to talk for 4 weeks to this medical student about health inequalities and encourage them to go off and experience different things. So well done, and keep up the great work. And I'm just going to move on to big picture now. So Prof. Kiran, you're doing some amazing work with, I'm gobsmacked that you had 3,000 people at the conference. I mean, that's incredible. How do we move it from it being a charity driving all of this great work to it being adopted as a mainstream part of healthcare? I think we're slowly on that journey a little bit, aren't we?
Yeah, I think the mere fact that we're doing things like this, Binita, tells us that we're on the right path. But as somebody said earlier, we are trusted professionals and people, and we've got to really use that to empower our communities. I think it's really interesting. We talk about racism, but actually we have a lot of conscious and subconscious bias in our system, and we've got to educate not only our patients and populations, but actually our fellow professionals not to have that subconscious bias. So, we've talked a lot about how we communicate with our communities, and we talked about the aunties WhatsApp groups. Actually don't underestimate how digitally literate our communities are. And when you talk about serving the needs of our communities, it's got to be digital, it's got to be non-digital, and it's got to be media-based, just like any other community in the world. We are no different to any other community in the world in order to serve their needs. But sometimes we just assume that we need to just translate something or get a translator in. And that's wrong. So we've got to challenge subconscious bias throughout the system. And the second thing I would say is really important is to tackle stigma head on. I went to a meeting in a community in Warsaw, and I said, what do you want to talk about? And they said, we want to talk about suicide, because somebody's daughter here committed suicide, and the woman stood up and talked about it. It was very emotional, but the community was absolutely engaged. So sometimes even we talk about stigma, and I think we avoid it, but we've got to tackle it head on. And we've got to wrap our services around that. And the third thing is, do everything we do for all of our patients, but do it well and focus on health outcome and not just equity of access, because sometimes to get the same outcomes, you need an inequity of access. And that is something that is poorly understood. Yeah.
Fantastic. Thank you. And just finally, I'd like to go to Race, who's out of everybody worked incredibly closely with NHS England over the last 12 months. And we've seen what is possible, Race, when there's resource and effort and people behind, a movement really to try and improve health information. And I think, the output from the vaccination programme, not just for staff, but for minority ethnic communities, was staggering, really, in the space of time that work was done. How do you think, Race, and this might be a hard question, and I know you're still early in your career, but I'm going to ask it anyway, how do you think we can make that a broader theme in the NHS where this sort of effort is put into tackling diabetes in a South Asian population, or heart disease, or respiratory disease?
I think you're right, Binita. It is a tough question, but I think the success of the vaccination program, especially with, for example, people from BAME, South Asian communities, has put it on the agenda. Where if it perhaps was something that wasn't on the agenda before, it's given a very clear blueprint of what works in terms of co-production with local communities. And personally, I'd really like to see this go down the new ICS route with GPs, ICS leads, really co-producing services for local communities by using the sort of networks and the distribution channels which were formed during COVID in the vaccination program. I think it's amazing that it's been brought to the fore over the last 12 months, and hopefully over the next 12, 24, 36 months, we'll really see that relationship cemented.
Fantastic. Thank you so much. And that's our hour up, actually. That's gone really, really quickly. I've learned a lot in that 1 hour conversation, and I'm learning all the time about this topic. It just remains for me to say massive thank you to all of the panelists, Seaman for helping put this event together, but everybody for giving up their evening to join us, for everyone who's watching. And I think just to take away, I think some of the key things that I've really taken away from that event is co-production, engagement, empowerment, but actually we do need that high level support as well. So it's got to be a bottom up, top down meeting in the middle to achieve what we want to. So thank you very much. I'm going to close it there, and hope everyone has a great evening. Bye.